I want to welcome everyone to the third annual DARA conference. We are so pleased to see you here on a Sunday morning, and we're glad that the weather is not as great that would have kept even more of you away. In any case, our conference chairman, Dr. Jeff Fialkov, is going to come up right now, and he's going to officiate and make the introductions.
Great. Thank you, Steve. Just make room for my iPad. These things are great. I was just saying to Howard how I have my notes written here, and my over 40-year-old eyes can't see anything in this dark, so thank God for new technology. I have an illuminated note. Okay. So welcome, everyone, and as Steve said, we, all of us here really appreciate you coming out on this kind of cool and drizzly Sunday morning. Just very quickly by way of housekeeping, those of you who are here and intend to collect CME credits, you must fill out an evaluation form, which I believe are at the registration desk, and please drop them off prior to your departure in order to receive your CME credits. And again, you'll receive 3 CME credits for this conference. I'd also just like to point out that the conference is co-sponsored by DARA, Doctors Against Racism and Anti-Semitism, and the University of Toronto Department of Surgery. And as an executive of DARA, I'd like to thank the Department of Surgery, and as a member of the Department of Surgery, I'd like to thank DARA. So thank you all. I had an interesting conversation with a member of DARA, actually, in the lead-up to this event. The member asked me what a group like ours, an anti-discrimination social activism group, is doing organizing a conference about war trauma and its effect on children. I have to admit my initial response was a little flippant, but since that time, I've formulated what I wish I had responded at the time when I spoke to him. Children are victims of war in ways that are distinct from adults. Firstly, they are often dependent for their survival on adults and on the relationships with adults that are often disrupted by war. The psychosocial effects of the physical horrors they witness, as we will soon hear, impact them on a developmental level with a profundity that we as adults can't really fully comprehend. The effect of weapons-related trauma has a higher likelihood of mortally wounding a child than it does an adult. And if they survive, the socioeconomic impact of a child's lifelong physical and psychological rehabilitation is far greater than that of an adult. Aside from ongoing medical rehabilitation, consider the cost of lost educational opportunities, the social stigmatization of child victims of rape, the effect of constant fear on cognitive ability and socialization. Add to that the ultimate exploitative phenomenon of child combatants, and you have an identifiable demographic group of individual human beings who are very vulnerable, suffering the penultimate in discrimination. I should have asked that member, how can DARA not present this conference? Most of us here in Canada have been lucky enough to not have to ponder the effect of war on children, but the world is a very small place, as you all know. And all around, the widespread destruction of health and lives of children rages on. I myself have treated newly immigrated adolescent victims of war here in Sunnybrook from Africa and from the Middle East, and sometimes they have unrehabilitatable injuries. This morning you will have the opportunity to hear about the effects of war trauma on the health and welfare of children from experts whose unique qualifications span the military, medical, and psychosocial realms, and whose unique experiences span the globe and time. So without further ado, I will ask Rob Zadek, who joins us from Israel via Skype, to introduce our first speaker. Thank you.
Thank you very much, Jeff. It is my great pleasure to be here in Jerusalem, Israel, to introduce our first speaker of the conference. I'm Dr. Rob Zadek. I'm the Vice Chair of DARA. Allow me to introduce Dr. Naomi Baum. Dr. Baum lives here in Jerusalem. She went to Bar-Ilan University, where she earned her undergraduate degree. She then went on to earn a master's degree in school psychology, as well as a PhD in counseling and child development at Bryn Mawr College. Dr. Baum was a fellow at the Mandel School of Educational Leadership and was the director for psychological services for a large rural school district. She has worked as a consulting psychologist for the school system from all the way from preschool through high school for over 30 years. She's taught psychology at several colleges and universities, both in the United States as well as in Israel. Currently, Dr. Baum is director of the Resilience Unit at the Israel Center for the Treatment of Psychotrauma and the National School Resilience Project. Her work focuses on developing programs to build resilience in communities that have been highly exposed to trauma and stress. She also works with police and fire departments. Without further ado, Dr. Naomi Baum.
Good morning, good afternoon, good morning, I guess it is in Toronto. It's my pleasure to be with you here this morning. And it's a curious kind of thing. I expected that since I'm giving you this talk here from Jerusalem, I wouldn't be having any jet lag. But guess what? I have jet lag. Came back from Rhodes in the middle of the night, and I'm suffering from jet lag. I could almost be in Toronto. So you'll bear with me today if I mumble my words or mix them up. Can you hear me okay? Are you hearing okay? Good. Okay, so we're going to just pop right along. And the PowerPoint, have the PowerPoint up there as well? Yes. Yes. Okay, so we're on the first slide, and what we're going to be talking about today is war trauma in children, risk and resilience. I first, before I get into the talk, let's move on to the next slide. I just want to acknowledge that we are a full team here. I'm one member of a team, and there are a lot of people who spend a lot of time working on the things that I am going to talk about today, and I just like to acknowledge them on the second slide. We're going to move along to the third slide, and I want to set out some of the goals of our talk today. I want to talk with you about how trauma affects children, and then I want to talk with you about resilience building, which puts a whole different spin on trauma treatment. If trauma treatment focuses on what's the downside, what are the risks, what are the problems that kids encounter, resilience building looks at the strengths that exist both within the system, within the family, and within the child, and looks to how we can use these strengths to help build resilience both in children, in families, and communities. Next slide. So we're going to start with our opening question, and that is young age a risk factor or a protective factor for the long-term effects of trauma on children? In other words, if you are a young child exposed to trauma, is this better or worse for you? Is it better to be older or younger? It's somewhat of an open question. We are beginning to get some answers on this, and I think that at first blush, adults very much like to think that children are not so much affected by trauma, that they don't really understand what's going on, that it kind of goes over their head. But the more we research trauma, the more we know that in fact kids are very much affected. And perhaps the single most important feature of how kids are affected by trauma is what happens to their caregivers. And if their caregivers have been threatened or exposed by trauma, then this is probably makes for the greatest impact on children. We know that when parents experience post-traumatic stress disorder, PTSD, and or depression, this greatly affects children. We also know that general poor family functioning, lower socioeconomic status, these are all the risk factors for developing PTSD. But again, I would call your attention to the fact that probably the single most important feature in PTSD, post-traumatic distress, call it, in children, in very young children, is whether their parents have been exposed to trauma and how they are coping with that trauma. When parents have trouble coping with that trauma, then their kids often suffer the effects in a much more significant way. Now, as you can imagine, it's not so. Well, let's move on to the next slide. Diagnostic challenges in infants. Are we? Okay, great. Okay, so we're having some challenges here of our own, are we not? But that's part of modern technology, and I guess we all, can roll with the punches. We're going to talk about resilience, and certainly being resilient is rolling with the punches. So we are rolling with the punches here, and we are going to talk about. We're still talking about infants. And we use the term PTSD in infants, although, I would kind of call question about that, because to actually diagnose infants with a psychiatric diagnosis is a little bit harsh to my way of thinking, and particularly when there are such significant challenges to working with young infants. First and foremost, all of us who have children of our own, or grandchildren or nieces and nephews know that very young children have limited capacities. So how is it that we're going to find out what's going on? How are we going to know if they're anxious? How are we going to know if they're not? Well, we'll know if they're not sleeping at night, but how are we going to know if that's related to trauma or not? So when we try to figure out what's going on with young children, what we're really trying to do is we're interviewing the significant caregivers, usually the parents. And 88% of we get from parental report. Young children manifest to adults different. And the way I like to think about it, young kids, their feelings are very much the same as grown-up feelings: fear and anxiety, happiness, sadness, but the way they can talk about or conceptualize it is far different. And the younger the child, the different more it is. So, talk about actually what kinds of things we might be seeing when children are traumatized. You can spot the next slide, talking about preschool reactions to trauma. We're talking like fear and separation anxiety, kids who don't want to leave their parents, or we're talking about loss of self-regulation, a lot of irritability, temper tantrums, maybe trouble falling asleep, going to sleep, being afraid of going upstairs to get something, even things like normal fear become exacerbated. Then there's the whole of trauma reminders, things that remind kids of the trauma. Be a place or a noise, sound. We have large segments of the Israeli population jump when they hear certain noises. These noises remind them of sirens. And if you go to the south and you hear something that kind of sounds like a motorcycle, you'll see kids jumping because it reminds them of the beginning warm-up of the siren. We very often talk about, when we talk about young children, we talk about regressive behaviors in general, return to bedwetting, thumb sucking, and things like that. And general behavior difficulties, sleep disorders and nightmares. And certainly one of the things that we know about young children is the way that they work out trauma is by post-traumatic play. So that if a young child has been in a car accident, what he will do is play and replay that accident. He might do it with his little cars, he might do it with stick figures, he might do it with drawings, but that is probably, he might do it with dolls, but that's the way he reworks trauma. Similar to adults, who they experience a trauma, they probably talk about what happened to them again and again and again and again. Young children replay their trauma. Okay, moving on to the next slide. I'm going to talk for a minute or two about some research that we've done here in our center, and it's really a very new study that we're just beginning to publish and talk about. It's a study founded by the Lear Foundation, where we took a representative national sample, 900 mothers, interviewed these mothers in depth about themselves, one of their children, 2 to 6. And our preliminary findings actually confirmed things that we knew before. We knew, we had a strong hunch that the most important factor in a child's post-traumatic stress was how much trouble his or her mother is having. And in fact, that is what we found. Maternal difficulties in regulation predict a child's distress. So that if a mother is anxious, a mother is hyper-aroused, a mother is having trouble sleeping and she's anxious, she in fact will pass that on to her child, and the child will experience distress. In our national sample, 1/3 of the children were exposed to trauma, and more than 1/2 of the mothers were exposed. And we know that Israel is a highly exposed population to trauma. As a matter of fact, when we talk about prevention work, when we talk about resilience as being preventive, because we talk about prevention in society where half of the adults have been exposed to trauma, and more than 1/3 of their children. One further finding that has been pretty significant is that there are different risk factors of the population. The Arab population was quite different than the Jewish population. People who live outside of what we call periphery or in towns and villages were quite different profiles than people who live in the center of the country in the major cities. And we could talk a little bit more about that. I want to just briefly run through elementary school students and high school students have their own set of to trauma. The younger the child, the more generalized kids have kids with stomach aches and headaches. Their school performance drops. How do we trump that's causing it? You never are sure. But if you can draw that connection that something has happened and then there's a change, you can be pretty sure that the trauma is playing a piece in it. And we know kids' ability to learn is affected by trauma, and we see kids in the southern part of Israel have had sporadic and ongoing exposure to missile attacks. There are lower grade point averages, absences from school, difficult to concentrate. And one of the things that we also notice is an increase in aggressive behavior, and that is one of the things that we're becoming more and more interested in here in Israel is the connection between trauma and violence, which seems to be a pretty clear connection to us. With high school students, what I'd like to focus on really is the self-destructive and reckless behaviors. We see that very often say, why do I have to follow the rules? Why go to school? Why play when nobody else is following the rules? And we see an increase in both boys and things like alcohol consumption, unsafe sex practices, strongly related to exposure to trauma, meaning that the more exposure to trauma, the higher risk taking behavior. We're going to take a quick shift here now, move into talking about resilience. And if up until now we trauma affected and what are the risks and what are the symptoms that we see, we're going to talk now about how in a post-traumatic environment we at what helps people. How do people face adversity? Because up until I think we're talking about trauma, who have higher levels of violence, are anxious, people sleeping, who aren't doing well in school. It sounds pretty miserable. But in fact, any of you who visited Israel, and Rob can probably vouch for this too, people are surprised by how resilient Israeli people are. And where's this resilience coming from? Does resilience mean that we don't have symptoms, just don't develop them? We develop them but recover faster? Where does this come from, and what is the nature of coping? So these are all some questions that we talk about, we ask when we look at resilience. And resilience is a word that's been used a tremendous amount in the last 10 years. If you look at the psychological literature from 12 or 15 years ago, resilience was a word that was hardly used. It was used very, very sparsely. And if you look at the number of articles
Naomi?
and their titles are
Naomi?
it's really expanded exponentially,
Naomi?
probably because of 9/11, probably because of what happened in 9/11.
Naomi?
Makes it easier.
Naomi?
Probably because of what happened in 9/11, people became very interested in trauma and resilience. So, the questions that we look at.
Naomi, can we interrupt for a second? Have to be out.
Sorry, we're going to
What?
interrupt you. We're going to interrupt you for a second, and at the risk of raising the ire of the audience, we're going to stop you one more time.
Okay, hi. Are we all on the same page? Are we up to resilience?
Yes, we are. Yes, we're up to resilience now.
Yeah, okay. Were we able to hear me thus far?
Yes. Yes, we were.
Oh, good. Good. Okay, so we're talking about resilience, and we're trying to understand where resilience fits into this bleak picture that I've painted. And the way I think it fits in is that it helps us look at the other side of the coin. When we're talking about trauma and we're talking about risk factors and we're talking about post-traumatic stress disorder, we're looking at the clinical picture of how a certain percentage of the population reacts to trauma. When we're talking about resilience, we're really talking about strengths that everybody has, capabilities that everybody has, and the idea is to put the spotlight on that and to really underscore the fact that in general, most of the time, most people, when exposed to trauma, actually do cope. Some cope better than others. Some cope more quickly than others. It doesn't necessarily mean that you don't have symptoms. You may have some symptoms, but you are able to keep on with your normal life, and you're able to muddle through or manage through. There are definitely things that we've learned over the years that can help people expand their coping repertoires and build resilience. So that spring is actually gives you a sense that what resilience is about. When there's stress and pressure, the spring is compressed, and then maybe a day later, a week later, a month later, the spring unfolds and people go back to their normal functioning, usually with some kind of added value. And if we move on to the next slide with Harry Potter is a figure that I like a lot because I think he happens to really epitomize resilience. Harry Potter was a youngster who grew up in very adverse circumstances, but he really seemed to be resilient. We have a couple of definitions here about resilience: the ability of a body to recover after stress. It's quite different from recovery because usually we're talking about people who haven't suffered greatly. They may have some symptoms, but not a huge amount of symptoms. We're not talking about people who are clinically either depressed or anxious or suffering from some other kind of clinical entity. We're talking about people who really seem to do okay after trauma. Maston is somebody who coined the term ordinary magic, which is a term I like a lot because it tells us that there's something magical about it. How is it that people who've experienced trauma actually manage okay? We hear sometimes some terrible things in Israel. We're always being bombarded, and I suppose you in Canada are as well. Tragedies about a week and a half ago, there was a terrible car accident here where a whole family, except for one young girl, was killed. And you say to yourself, how is that girl ever going to build a normal life? And yet we hear stories and know stories. We all know personal stories of people who have come out of great adversity and gone on to live good lives, creative lives, productive lives, and this is what Maston calls ordinary magic. There's something magical about it, but it is quite ordinary in the sense that it happens all the time. And the last point that I'd like to make is that very often what we're talking about is not going back to everyday functioning from before the trauma. We're talking about bouncing forward because people, once they experience trauma, do change. They're never quite the same. So to say that they've bounced back is probably a misnomer, and what we want to talk about is bouncing forward. And now let's move on to the picture of what I consider the Israeli symbol of resilience, which is, as you all probably can recognize, the cactus, the tzabar. And that is actually a beautiful picture of a tzabar. We have that green, prickly cactus plant, but what we have, not only do we have the plant that has its prickers, we have those fruit. And the fruit are really luscious fruit. I don't know how many of you have tasted a tzabar, but they are quite delicious, and on this picture they look absolutely beautiful. And we do have our prickers, but we are sweet inside, and that's what they say about us Israelis. But I also think this is part of our resilience. The prickers are part of our resilience. We are a little bit prickly. That helps us to protect ourselves from our enemies, protect ourselves from difficult times. But at heart, there's a lot of goodwill, and in Israel, one of the major features, I think, of community resilience is the tremendous amount of social interactions there are, social support. The way people interact with each other in community is one of the overwhelming features of resilience in Israeli society. Now, just stepping back from a societal level to a more individual level, let's move on to the next slide, talking about protective factors in children facing trauma. We know, specifically when we're talking about young children, that, again, the parental relationship is probably the most important feature of resilience in children. Physical proximity of child to parents, and then social support and community support. But I would say that the relationship with the parent and how the parent relates to the kid is the single most important feature. And to that end, and let's move on to the next slide, one of the programs that we have developed is called the Namal program, which is a program, let's make room for play. We are reteaching parents how to play with their kids. One of the things that we have found is in a peri-traumatic society, and we saw this very clearly in Sderot, in the southern part of Israel, that young children lose the capacity to play when they are constantly exposed to trauma. And parents, as their caretakers, forget how important play is for children. They are very worried and concerned and focused on safety, in making sure their kids are safe, making sure their physical needs are taken care of, but they forget how important play is. And in our program, which is a 10-session program, what we do is we reteach them how to play. There are 10 meetings, and there are different themes in each meeting, and each meeting has a different song and a different game, and it's parents and children interacting together, playing together, while the parents are introduced to the very basic concepts of trauma and resilience, and they are reintroduced to their children and playing with their children in a safe environment. So this program we've evaluated as we do all of our work, and we've gotten some very, very good results from this program. Another program that we have developed is the ecological model to resilience building. And here you see it's a program that we've done all across. It's the next slide, slide number 18 if you're following along with me. You can see a picture of Arab mothers, Arab preschool teachers. They're not Arab mothers, they're Arab preschool teachers up in the northern part of Israel. In the post-Lebanese war, we took this program all over Israel to a wide variety of cultural and religious contexts. And the idea is that we train educators in resilience building, teaching them skills and tools that they can use in their own lives and then bring into their classroom. In addition, we do group screening for PTSD in schools and in-school group treatment and parent resilience groups. I'm going to just run through the next couple slides so that we can get to the question and answer period. The next two slides, we just flip them by, have to do with the screening projects that we've done with Israeli adolescents and school-age children, looking at trauma, looking at how many kids have been exposed to trauma. We know that more than half of the population has been exposed to trauma, even when we're talking about young children, talking about direct exposure. Certainly if we're talking about indirect exposure, 100% of the population has been exposed. And if we talk about fear and helplessness, we know that a lot of it is related to how soon after the trauma we measure it. children and adults, if they are measured within a month or two after trauma, will show very high levels of symptoms of fear and helplessness and post-traumatic distress. If we measure them a few months later, the numbers go down very significantly. And so what we've done is we've developed a model. I call it the BRI model, the Building Resilience Intervention Model, and it's based on these four pillars: self, strength, support, and significance. And we've taken this model and used it really in a wide variety of settings. We started off using it with teachers, and then, as Rob mentioned, we've adapted it and used it with firefighters and with policemen. And in general, what we're doing is we're giving, we can move on to the next slide, which is workshop guidelines. If you've moved on from the BRI model to workshop guidelines, what we're doing is giving professionals a time out to stop and look at how they're doing. And interestingly enough, we found that this model works beautifully in a wide variety of cultural contexts and in a wide variety of post-traumatic environments, ranging from war, terrorist attack, natural disaster. We brought this program to Biloxi, Mississippi, and we met with teachers a year after Katrina. And when the first workshop session, we met with them and we said, we're not really quite sure how this program is going to work here because we've only used this in Israel in post-terrorist environments. And we stopped and said, how are you doing? And did some workshop activities with them about where they were and how they were doing. And the teachers were astounded. They said, this is the first time in a year that anybody has asked me, how am I doing? I haven't checked in with myself in a year to even know how I'm doing. So one of the things that we find in post-traumatic environments is that it's so important to stop and have people take a look. How are you doing? How are you coping? What's working for you? We also do some teaching about trauma and about recovery, normalizing their experiences. Very often people feel like some kind of screw has come loose in their heads. They're not like they were a year ago or 2 years ago. And learning that their symptoms are normal and similar to other people who've experienced difficult events can be very reassuring. We work on developing skills which may be breathing and mindfulness, looking at what kinds of talking about emotions, talking about what helps me when I'm feeling stressed out, what works for me, acknowledging individual differences. All this is part of the work that we do. And when we're working with teachers, the notion of self-confidence is very important as well, because what we want the teachers to do is to go back into the classrooms and be able to talk with kids about trauma and to impart to them some of the skills that they have learned. So self-confidence is very important. And next slide, please, where you can see some of the cross-cultural implementation. We did this in Biloxi, Mississippi. We've done it with the Ethiopian community in Israel. You saw a previous picture of the Arab communities in Israel. And the bottom picture is a picture in Haiti. And our final slide today, where I want to just conclude with noting that children are particularly vulnerable, and we must pay attention to them. We'd like to think perhaps that trauma doesn't affect them or that they don't notice or they don't understand, but really they understand a lot more than we give them credit for, and we have to be available and open to helping them get through whatever it is that they've been exposed to or experienced. A major challenge in implementing these programs is to make them sustainable, because what happens very often is we bring them in, we're the experts, we bring them in, and then everybody's all excited about it, and you're, a week or two or a month or two or maybe even a year after trauma. But how do you build these programs so that communities can sustain them and that the existing resources can maintain them? That is a very big challenge to all of our work. And finally, I would say that while all of our programs involve evaluation, it's very important for us to help expand the evidence base of the effectiveness of these programs. We have some studies that we have done showing that teachers who have undergone our resilience building workshops, their students have significantly less post-traumatic distress and post-traumatic anxiety. And that's the beginning of the evidence base of the effectiveness of these programs. And it's so important for us to do that so that policymakers and practitioners will actually be very interested then in adapting these programs system-wide. We're talking about very short-term, effective programs that can be adapted and used to help children cope with trauma, whether it be man-made, war, terrorism, or natural disasters. So I'm going to now turn this over back to you for questions. I'm happy to answer any questions that you have.
Thank you very much, Naomi. I apologize for the technical issues. It was an excellent presentation. If anybody,
I hope you were able to hear most of it.
We did. Thank you.
Okay.
If anybody has any questions, they're going to need to.
You need to be around that area.
You need to come to the front. So, does anyone have any questions for Dr. Baum?
Or you can repeat it.
I don't know if
Jeff,
we can.
or you can repeat it, Jeff.
No?
Maybe just repeat the question.
Or I can repeat the question if you want to just throw a question at me. Anyone have a question for Dr. Baum? Dr. Samuel?
Thank you for your talk. How applicable are your techniques in young people to non-post-traumatic psychological conditions which include anxiety, for example, OCD?
Yeah. Great question. That's a great question. And in fact, a lot of what we do, I always look at our work as sort of the silver lining of trauma, because I think what we're doing is we're really bringing general mental health skills and knowledge to populations that otherwise have shied away from mental health, because mental health tends to be stigmatized, we know. And nobody wants to be crazy, nobody wants to think their kid is crazy. So, but when trauma happens, all of a sudden it's sort of like a window of opportunity, and people are more willing to entertain ideas that are more psychological. And I think that we've seen that in Israel, that there's been a great opening in the system in terms of willingness to talk about mental health and bring in mental health practitioners. So while I don't have specific experience about OCD, I would say that generalized anxiety our programs would be very useful for. And I am sure, like with any population that we come into, we always have to do some adaptation. You can't ever assume that your program is going to be a one-size-fits-all. But we have been really very gratified realizing that this seems to be the basics of good mental health. It's noticing where you are, what helps you be self-regulated as an adult, learning how to talk about your own emotions and listening to kids' emotions, and then giving some skills, teaching some actual skills. The last point that I forgot to mention in the course of my talk, I think I had an S up there for significance. One of the pieces that is very important in the trauma work that we do is building meaning, making meaning out of trauma. And that might be, again, I don't have a lot of experience in OCD. That might be relevant or less relevant, but in trauma work, making meaning out of why has this happened? Why has this happened to me? What do I do with it now that it's happened to me? How can I live my life differently, better? How can I make value out of the trauma is so important. And that's a piece that we have in the resilience building as well. I believe on slide number 21 we should have that significance. Yes, and we do have S for significance, and I really didn't speak to that. But I think your question is an excellent question, and we really do or can use a lot of these things in more generalized mental health work.
Thank you. We have one more question for you, Dr. Baum. I don't think you have to leave.
Okay. My name is Dr. Margulies. I'm a psychiatrist. And I was wondering if you have any comments to make or observations, data, about the long-term effects of trauma on the children you see. You've been talking primarily about sort of the acute effect, classical, childhood classical PTSD. What about what we call complex PTSD, the long-term effects in adulthood, and some people call them personality disorders.
Right, right. So, you know, when you're talking about complex or type 2 PTSD or pervasive developmental disorders related to PTSD, you're talking about kids usually who have grown up in environments that have been abusive or neglectful and have had ongoing traumas of a different sort. And there the results are really quite pervasive and very pernicious. What I've been talking about is natural disasters and wars and traumas that come from outside the family. And I think the advantage, if one were to choose, and obviously nobody chooses either kind of trauma, if one were to choose, one would say that traumas that are based outside of the family, in other words, that were not brought upon by a family member, it makes it a lot easier in a lot of ways to deal with. And in the long term, well, we don't really have long-term figures. We know that in any population that we see, traumatized population of children, there'll be about somewhere between 5 and 10% of kids who have very significant difficulties that these building resilience groups are not enough for. That really, they really need treatment. They really need individual treatment or group treatment to help them with their difficulties. When you're talking about the developmental disorders, that's much stronger, much more pervasive, and much more long-term.
Thank you very much, Dr. Baum, and thank you for joining us here via Skype initially and now something slightly more reliable. We really do appreciate you joining us for this and sharing your experience and obviously your expertise with us at what is an inconvenient hour for you, but thank you again.
Not so inconvenient.
And Rob,
you're welcome. You're very welcome. It's been a pleasure.
Thank you very much.